has negotiated a rate with the university that they're willing to pay. Remember all those rates I showed you? The 19,000 versus 42,000? None of the independent yet, well, we only have two, have negotiated rates with our insurers. So our insurer has to pay the full bill they give them without asking. They have no choice. So they have a captive market. And then there's limited financial regulatory barriers that prevent new suppliers from entering the market. I didn't really know how that applied, but I wanted to talk to you about those two. So I want you to remember, you're going to pay $150 no matter which one you go to. And two, your insurer has to pay the bill no matter how much it is. And three, the emergency department has no incentive to negotiate a price. Now, all the hospital ERs, they negotiate prices because they'll get you if you're hospitalized. And they want you to stay there and not be sent to a different hospital where the insurer has a better rate negotiated. So what determines the cost of insurance? The actuaries look at the health of the population, and this is what's thrown insurance into such chaos now. They used to be able to discriminate against people who were high risk and high cost. They can't anymore. They look at the cost of the service that was provided and the frequency of use. Okay, so if this population if this population goes to the doctor 10 times more, their insurance premium is going to be more because they're using it more. You might have heard about Summit County and the mountain communities and how expensive their insurance is. Because there's no competition there, the providers get to set their rates, and that's why their insurance is so expensive. Because all the providers there can get paid almost whatever they want, because the insurer has one person to negotiate with, so they don't get to negotiate a price. Oregon had this situation, I don't remember how many years ago, but they could give let's say 20,000 people Medicaid. There were 40,000 people who wanted it, so they had a lottery. And the 20,000 people who won literally got Medicaid. The other 20,000 didn't. But what they did was they followed what happened to them over time. And you might have seen the article. They weren't seeing a huge difference actually in health outcome yet. It was only a year or two. So as a primary care doctor, I would say give them 10 years. But anyway, but what they did see was that once people had Medicaid, they went to the emergency room 40% more often. And the reason why is because they only have to pay that one price, right? And if they can't pay it, the ER has to see them anyway, because those are the rules for emergency care. Now, my private insurers tell me that this happens with private insurance as well. The people who never went to the doctor before, that as soon as they know they have private insurance, that's just that $150, they're more likely to go to an emergency room and get care. So, this is data from one insurer on the independent freestanding ER in Colorado Springs. I don't think this would be Arvada because the data only goes through September. Didn't the one in Arvada open in like November? Or am I wrong? But anyway, so one insurer, okay, they were charged $1.9 million. Of that, $1.7 million was facility fee. $240,000 was for services delivered. So this is what I want to take care of. Now, if you can see enough people and do a bill for enough services to keep your model going, great. But in my mind, this is corporate welfare. I'm keeping your business alive, and you're not doing the work to pay for it.
Is that a freestanding, one of these freestanding ER clinics? Okay,
It's
so that's
one.
not a hospital. That's
No,
actually...
this is a freestanding ER in Colorado Springs. One insurer, okay? And when they came to testify, what they told us was that they were seeing 400 people a month, that 25% of them were not insured, which means they're seeing 300 paid visits a month. And they have a doctor on staff for 720 hours a month to see those 300 paid visits. So what were those visits for from this one insurer? 60% were for non-emergency care. 16% were for conditions that might have needed immediate access to specialists. So those people are going to need to be transferred by ambulance to a hospital and create a new ambulance charge, maybe a new ER charge, maybe not, but a hospital charge. And so this is why you're being told by First Choice that if we get rid of facility fees, we're gonna close them down. But really, to me, that's because this is all we're paying for. Now, if there were no other emergency room, yes, we would subsidize this, because you would need an emergency room here. The distance between First Choice and Lutheran is 4 miles. If you are having a heart attack, you should not be driving yourself anywhere. Call 911, chew an aspirin, and then call 911. If you are having a stroke, you should not be driving yourself anywhere. If you've just been injured in a motor vehicle accident, you're bleeding, you should not be driving yourself anywhere. And if you call 911, you will be taken to Lutheran or St. Anthony's or whoever has space. And so, in some cases, in our rural areas, Medicare actually pays them more for everything they do in their hospitals, because they want the hospitals to stay open even though they don't see enough people, because there's a need, there's medical necessity. In this case, I guess my argument is that there's not a need. And this is what I'm afraid of. So this is Houston in 2004. These little 4 light blue dots were how many independent or freestanding emergency departments there were. This new model that First Choice is following, and there are other companies that are following it, came into being. This is how many emergency rooms there are in Houston now. This is a change in 10 years.
None of those are associated with hospitals.
I don't know if they are or not, but this is how many emergency rooms they have now compared to then, 10 years. Now, what I can tell you about this is 2 things. One is that, actually, interestingly, I had sort of seen this, and it had raised my concern about this being a way of milking the healthcare dollar without necessarily adding value. And then these doctors came back from the American Academy of Emergency Room Physicians annual meeting. And what they said to me was that Herman Hospital, which is the equivalent of Denver Health, was having trouble finding emergency room doctors to staff their emergency rooms because there were so many other places that they could work. And I mean, who wouldn't want to see 300 patients a month instead of 3,000 patients a month? I mean, you know, I can't blame the doctors. It's a much easier job. And so because of that, the ER that you would be taken to when you had a motor vehicle accident might not have the best doctor in it because they were being drawn to these other places. So this was also for me a workforce issue. Now, if there are these many ERs that are making business, then we probably need some kind of medical care there. But as a primary care provider, what I can tell you is that our insurers need to figure out how do you pay primary care so they keep their offices open until 11 o'clock at night and all day on Saturday and Sunday. Because remembering this, if only 16% of them needed emergency, real true emergency care, we should not be having them go to these places where we're going to be paying mostly for facility fees and not so much for the service that's being provided. This is Colorado Springs. This is the First Choice of Colorado Springs. The red are where there are hospitals with hospital emergency rooms. The blue are urgent care centers, which again, 60% of their visits could have been seen at urgent care. And those are within 10 miles of First Choice. So it's not that there isn't an option. This is the same for your freestanding emergency room here in Arvada. This is it. The red are the hospitals, and the blue are urgent cares. So there are 6 hospitals and 5 urgent care centers within 15 miles of First Choice ER. This is what I wanted to talk to you about the copayment. This is actually a Jaguar. This is a Hyundai Elantra. If I said to you, you pay me $150, which car do you want? What are you going to pick? You're going to pick the Jaguar or the Hyundai Elantra? I mean, if nothing else, you could pick this, sell it, and buy 3 Hyundai Elantras, right? Because the prices are significantly different. Well, it's not quite exactly the same, but for your $150, or whatever your copay is for emergency care on your insurance card, you can either go to Lutheran and deal with the inconvenience and the wait, or you can go to First Choice. what are you gonna do? It's human nature. You're gonna go the first choice because they're only seeing 300 people a month, and it's gonna cost you the same $150 one way or the other. So why wouldn't you? Who's gonna pay the rest of the price of that car? Everybody who's buying private insurance is gonna pay the rest of that price of the car. It's not the state. Well, it will be our private insurance rates for our employees, but our Medicaid will not be paying it, Medicare will not be paying it, TRICARE will not be paying it. The private insurance will be paying that. I'm gonna stop there because I feel spent. I just want to let you know that, and this is the thing that's most annoying maybe, only 10% of your health is determined by access to our healthcare system. 40% is behavioral. Please don't smoke. Get healthy. Quit smoking. If you don't eat healthy, please eat healthy. If you don't exercise, please exercise. 30 minutes a day, 5 days a week. Marked improvement in heart disease, in Alzheimer's prevention, in bone density, decreased fractures for women. Big health benefits and behavioral things. 30% is genetic. I tell my mom I can't write off what she sent to me. But we spend, I heard this number is $2.8 now, trillion on something that only determines 10% of our healthcare outcomes. And I want to help us get more value for our dollar that we're spending. The other thing I want to tell you is this. As I mentioned, I have a daughter who's significantly disabled. So, and I frequently hear people say, I'm young, I'm healthy, why do I have to spend $600 a month for health insurance? This is why. Because actually only 5% of our population spends 50% of our healthcare dollar. My daughter's probably in here. If you don't know anyone who's a paraplegic or quadriplegic, they're probably in here. If you know anyone who's had a liver transplant or a heart transplant, they're in this group. So those of you, those of you who are healthy and are saying, why the heck am I paying $600 a month when I don't use any health care? I just want you to know that you are paying for people like my daughter. You're paying for your neighbor who's had a heart attack or stroke. You're paying for that child who needs a congenital heart repair. That's why you pay so much for insurance. And the other thing you'll hear a lot is complaints about how much money we spend on Medicaid in our state. And the reason why is that we get those patients like my patient. So we spend 60% of our Medicaid dollar on 17% of our population. And those are the elderly and the disabled. Children, parents, they don't cost us very much. We get a good return on investment for this because we're saving ourselves money down the line. But the reason the state Medicaid budget is so high is because of our elderly and disabled. Even after full implementation of the Affordable Care Act, it had gone completely smoothly, we are expecting to still have 400,000 people uninsured in the state of Colorado. 40% are because they're undocumented. And everybody has a different opinion on that. 22% are people who say, screw it, insurance is too much, I'm just gonna pay the penalty, I'm not gonna buy insurance. 30% are people who would be willing to buy insurance, but they really still can't afford it. So they won't be charged a penalty, but they're not gonna have insurance either. So there are still going to be people coming into our hospitals needing care who have no way to pay for it. So what I'm really about, this is just my Band-Aid, what I'm really about is creating a plan where we have nobody who's without insurance. And my idea for how we do that is called cooperative, where we all pay into our insurance system in our state. It's a percentage of your income, so nobody gets a free ride, but if you have more, you pay more. It's capped at an income of $450 for a couple, $350 for an individual, because we shouldn't have someone pay infinite amounts of money. And I had an economist from the University of Massachusetts, Amherst, do an estimate on this. And this is what he said percentage of gross state product would be with the Affordable Care Act, with doing nothing, and with implementing my cooperative plan. So I'd be thrilled to come another day and tell you about my cooperative plan. But in the interim, I just wanted to tell you why I felt so passionate about Senate Bill 16. Thank you. I'm happy to take any questions.
Awesome. So I think we'll let Lauren come and talk to about why their model is a bit different and why it doesn't work, and then we'll take questions from the audience. I was remiss though, I missed Bob Loveridge, who is one of our directors at Apex and is a candidate for the fire board, and Tom Marks, who's also a candidate for the fire board. So Lauren, if you want to come talk for a few minutes, and then we'll take questions.
My name is Lauren Raleigh. I'm with First Choice Emergency Room. I'm Vice President of Government Affairs. I'm joined today by our Facility Medical Director, Dr. Neil Albert. And I'm going to let him do the majority of the talking. That was a lot of information you just had. So I'm going to actually speak directly to the bill and what it does and why we disagree with it and why we're going to continue fighting it. Thank you so much for allowing us to be here today, Tio. We really appreciate it. We came to Arvada and to Colorado Springs because we saw these areas as being underserved for emergency medicine. So we chose these locations because of that. The community has really embraced us, and we're very appreciative of being here, and we want to continue being part of this community. Senate Bill 16 is aimed directly at putting us out of business, by saying it is a crime for us to charge a facility fee. We look, act, and provide services just like a hospital emergency room. In fact, an apples-to-apples comparison versus the orthopedic hospital on the slide would be a freestanding ER for a hospital. If tomorrow we were open, we shut down today and Lutheran took us over, they could open us tomorrow and be fine. They would not be subjected to this law. The facility fee, what is the facility fee? And is it directly affiliated with the hospital? No, I would argue it's not. And nowhere could I find any definition that said facility fee pays for the hospital. Facility fee pays for the ER nurses, the radiology technologists, the on-site laboratory and digital imaging capabilities, the crash carts, the infrastructure, and being open 24 hours a day, 7 days a week, which, by the way, our license in this state requires us to be. We are licensed as emergency services provider. Urgent care, which was mentioned, they're not. They're not licensed by the state. There's no requirement they be open 24 hours a day, 7 days a week. It's also interesting, as I was looking, and I also want to say, we do try to provide a lot of information to the community to say we are an emergency room. We are not urgent care. I have a colleague here with me, Andrew, who's got some information. He's happy to provide anybody who wants it, that kind of explains the difference between hospital, urgent care, and us. And we want, we don't advertise as anything other than emergency. You look at our building, we're emergency room, not urgent care. So I think that's an important distinction. Interestingly, in 2012, and there's a lot of talk about the ACA today, a law was passed that was associated with that. It's regarding essential health benefits. So the legislature, in its wisdom, said there are 10 essential health benefits that must be covered by insurance, one of which is emergency services, provider and facility fees services. Nothing about hospital, nothing about emergency services provided at a hospital, and that's what we came to do. With regard to CMS, it's true, we're not licensed by them, but that's really because we're a new industry, and just like ambulatory surgical centers, we expect someday to be recognized. I'm going to hand it over to Nils, but I just want to say we really want to continue being part of this community. We really would appreciate everybody's turning out today to hear this important debate, and we're going to fight this legislation till the end.
Thank you. My name is Niels Albert. I am the Facility Medical Director at the Arvada facility. I first want to thank everybody here in Arvada for embracing us and bringing us into the community, and I feel it is a necessary part of the community to provide top-notch emergency medicine care to the citizens of Arvada. Arvada has grown over the years, and they're at a population now that I think warrants more ready emergency access than what they've had available in the past, and we are there for you. I had a few things I wanted to say to kind of maybe elucidate what Senator Aguilar talked about and some of her teaching points here on the slideshow regarding some of the issues. EMTALA, this is a law that is mandated, federal law that mandates that all hospital emergency rooms, all emergency room designated facilities have to provide an emergency medical screening examination to all patients who walk through the door. All patients who are in immediate need of care for injury or illness shall be provided the care to stabilize them, at which point, once they're stabilized, the next step of care is to be provided whether they are admitted to the hospital or sent to a facility that can care for them better. At First Choice Emergency Room, the facility has a blanket policy. We see absolutely every patient who walks through the door, regardless of your condition. You walk through the door, you are seen by me, the doctor on call, the doctor on staff. It is then determined if you have a life-threatening situation or an illness or injury that needs to be treated, you're just cared for. It doesn't matter your ability to pay. Now, for that type of patient who has no insurance, Medicare, Medicaid, TRICARE, those patients never see a bill from us. It's free, gratis pay, it's care. I can say in the years that I worked as an emergency physician at Lutheran Hospital and other hospitals, the same thing applied to every patient who walked through the door. The difference was, a patient that couldn't pay at the door or had Medicare, Medicaid, TRICARE, they received a bill. And so then they spent a lot of time working with the facilities and the hospitals to figure out that bill. Again, at First Choice, it is our pleasure and our honor to be able to care for.
Yeah, and I was just going to add to that. We supported the legislation when it actually required, when the legislation had a licensing component, we actually supported that state license, that as a requirement of our license, that we have to treat anybody regardless of their ability to pay. We're 100% supportive of that. I just wanted to add that we don't mind if that's legislated here.
Regardless. Now, as far as emergency care is provided in our facility, if you're in our facility and we're able to stabilize, care for you, and release you home, you go home. If you need to be admitted to the hospital, vast majority, almost every patient who is being seen in our facility does not go to another hospital emergency room. They do not incur a secondary cost. You are admitted directly to a hospital. You bypass the emergency room. And we have the contracts, we have the abilities to work with surgeons, hospitalists, orthopedists, to get you directly admitted just as if you were in the emergency room of a hospital or one of their hospital freestanding emergency rooms that are hospital affiliated, okay? I also wanted to touch on the urgent care model. It is very different than the emergency room care. You can't compare First Choice emergency room to urgent cares. Number one, urgent cares have limited capabilities. They have limited staff, they have limited hours. So if you are coming into an urgent care with a problem that they perceive is beyond their ability to care for, they just basically tell you you need to go somewhere else or they'll call an ambulance for you. And you won't have this happen at First Choice. You will be cared for, you'll be seen, you'll be screened, you'll be evaluated and treated. I've also experienced at urgent cares, if you don't have any insurance and you can't pay whatsoever, they won't take care of you. So they won't take care of non-paying patients, even if you're sick. And lastly, urgent care is closed. So if it's 7 o'clock or 8 o'clock at night and the urgent care closes at 52nd and Wadsworth, guess where you're going to go? You go to Lutheran, you come to First Choice Emergency Room. We have a pretty good relation with First Choice, with the urgent care near us, and we work with them in two ways. If they have a patient that they feel is really sick, we're one of the options that they provide. If we have patients that we see and they ask us, hey, is there a less expensive alternative to your facility? We say, yes, there is primary care physicians if you're stable to go, or there's an urgent care down the road if you're stable to go down to an urgent care. So one of the nice things that all of us at First Choice have the ability to do is talk to our patients and provide them with some education with their healthcare choices. As an attending physician in a hospital-based emergency room, my job is to be back there and see patients who are placed in a room. I never had the opportunity to actually be part of the decision-making process with the patients up front when they actually had questions about alternative healthcare choices. And I find that's really refreshing that I can actually educate my patients without actually billing them or having to take care of them if they don't need to see us. And they really appreciate that as well. I'm also very impressed by the citizens of Arvada who, as Senator Aguilar says, have co-pays. They actually look at this and say, boy, this is a $150 copay, and I really just have a splinter or a sore throat. Is there an alternative to this? And I said, well, is there anything else that we need to do? You know, let's take a look at you and see if you're stable. And we have a little discussion, which is wonderful free care, and we actually help them and move them to a different choice if they choose. And so, again, I really enjoy the fact that we don't have to see everything that walks through the door. If they don't want to be there, we give them those choices. but I also enjoy seeing that sore throat or that earache or the vomiting patient at 2 in the morning when they are really sick, and I'm glad that they didn't have to drive 5 miles down the road, throwing up in their car or really feeling awful, to go to Lutheran Hospital to wait 2 hours to be seen for something that can get taken care of in 20 minutes. I can get these people in and out of the door that fast. So it's all about choice. And I think first choice emergency room, the freestanding emergency room model has evolved with the community, it's evolved with medicine, and it has been born from physicians, emergency room doctors, who have seen a flawed system and figured out a way to make the system work better for medicine and for the patient. And that's what first choice really stands for. We have, our services are transparent. We all wear emergency room clothes. We all talk about who we are and what we are and our capabilities. So nobody comes into our facility trapped. Nobody comes in our facility feeling like they've been sucker punched. It's open for discussion. Our main primary objective is just to care for our patients, provide excellent care. And we have wonderful testimony. There's another example down in Colorado Springs. We had a woman go into labor who wouldn't have made it down the road to the hospital several miles down. And Dr. Price in the back of the room had the opportunity to deliver a child who had the cord wrapped around its neck and probably wouldn't have survived very well had that child delivered on the side of the road waiting for EMS to arrive for the ambulance. Dr. Price has a wonderful picture and testimony from the family thanking us for our services. We've had patients come in with heart attacks, patients who are 75 years old. I screen, I treat, I call up the cardiologist down in Lutheran Hospital, and I send them directly to the catheter lab, and they get their care appropriate. It's a wonderful service we provide, and I hope to be able to be here tomorrow and next year, and I hope that we have facilities in other communities to provide the same type of care that we have for you. Thank you very much.
Absolutely. We'll let the doctor respond, and then we'll take questions from them.
So I just wanted to say a couple of things. You know, she is right. The way that the bill is still written, the current amendment would allow Lutheran to come and buy that facility and run it and get the facility fee. And so I actually am going to amend it so that only emergency departments that are physically part of a hospital can have the facility fee, because I think that you're absolutely right, that's only fair. It would be possible for you to stay here if two things happen. One would be if you saw more patients or you changed to urgent care. The second thing is that actually what I am told is that CMS, TRICARE, and Medicaid have been billed by First Choice. Well, I shouldn't say that. Medicaid has been billed by First Choice and has reimbursed for services provided, but has not reimbursed facility fee because that's been adjudicated at the federal level, and CMS does not have to reimburse facility fees. And then the essential health benefits, I need to double check that emergency services include provider and facility fee. I know that that's paying emergency centers. I did not know that it was specified provider and facility fee, but I think that's another reason why your insurer is trapped and has to pay whatever bill is given to them. And I think the biggest difference for me between First Choice and an ambulatory surgical center is that your insurance can choose to contract with them or not if you're an ambulatory surgical center. Because this is an emergency room, A, your insurer doesn't have a choice, and secondly, there's no pressure on the provider to contract. And what I've been told is that only one insurer has had an offer for a contract from First Choice, and their facility fee was significantly higher than all of the hospital facility fees, so the contract was not taken. I do think that that as the statistics show that there certainly is a population here to warrant more access to care, but the statistics show that 60% of the care was actually not emergency care. And then I actually also wanted to say that if they do need to send you to an emergency room at a hospital, you do get an ambulance bill. I'm sure there probably are some hospitals that will directly admit you, but you are not saved from that extra cost. And this is the hardest part of what I talk about every day, because at the end of the day, who wouldn't want the Jaguar?